Thank you all so very much for joining us today for our Doctors in webinar on falls prevention in webinar format for obvious reasons. For those of you who have been part of the Doctors in before, welcome back. For anyone joining us for the first time, Doctors in is a series that we do as the LGBT Elder Initiative in partnership with Jefferson, the Jefferson Center for Urban Health, and the Department of Family and Community Medicine, which houses the Geriatrics Division. And so we've had this partnership for about 2.5 years now, doing these monthly health presentations for the LGBT community on a whole range of topics. And so we're excited to be able to bring this one in virtual format to talk about falls. So just a couple of logistical things when talking about the Zoom webinars. So you should all have access to the Q&A feature, which will be in the bottom toolbar on your screens. And so that is a place that you can submit your questions at any time to the moderators. That the presenters will be able to answer those questions as they go, or we might save some for the end if they're going to come up later in the presentation. You will also, there is an option when you do that you can select to submit your questions anonymously. If you're asking something that maybe is a little bit more personal and you don't want other folks to see your name, that is an option when you submit your Q&A, use the Q&A feature. You should also have access to the chat. The chat is public, so you are welcome to put things in here. Again, comments, questions, but just know that everyone is going to be able to see what you put in the chat. So the Q&A feature is better for questions where you might want some more privacy or have the anonymous feature. The chat, you'll be able to put your thoughts out and everyone will see them. We are also streaming live on Facebook. Anyone who is watching us on Facebook can put their questions in the comment section as we go, and I will check back on those occasionally to convey those questions to Dr. Spina as she presents. So without further ado, I'm going to introduce Dr. Elizabeth Spina. She is a geriatric fellow at Jefferson within the Department of Family and Community Medicine. This is her first Doctors in program with us, so we're very excited to have her here. And I am going to turn it over to Dr. Spina. So welcome.
Thank you. Thank you everyone for having me. I'm very excited to be here. Like David said, my name is Elizabeth Spina and I'm one of the geriatric fellows at Jefferson Hospital. And today I'll be talking about fall prevention. And it's a perfect time of the year to talk about fall prevention because in the month of September, there is a week devoted to fall prevention awareness. So I hope you all take something away from this, and please feel free to ask questions throughout, and David will interrupt me. So the first, this is just an outline of kind of what we'll be reviewing today, why we care so much about falls, what is the actual significance of falls, who is at risk of falling, and if we can help prevent falls, what can happen if you do have a fall or someone you know has a fall, and then what kind of tools can we use to prevent them again in the future, how to use walking aids and when to use them, and then where to go to get more help. So I think it's very enlightening to define a fall, and one area in particular, but a fall is an event which results in a person coming to rest to the ground, or another lower level, which I think is important to highlight. A lot of people don't consider just a trip and a slip to be a fall, but you don't need to come to contact with the ground. So someone can have a fall and catch themselves on a chair or a couch or a stool, or someone can catch them. And those are more of what we would consider as a non-traumatic fall or without serious injury. And that's a really important time to recognize that it is a fall, and that's a good time to intervene and minimize the risks for further falls. So why we care so much about falls in older people is because 25% of community dwelling, meaning living in an apartment, a house, living with a family member or loved one, they fall about, or 25% fall a year. And after you get over the age of 80, 50% of people fall yearly. People that live within nursing homes, 50% fall as well yearly. And so we care about this so much because you can have a fall that leads to a serious injury, and 1 of 5 falls leads to serious injury. It's the leading cause of accidental death, and it's the 7th leading cause of death within people over 65 years. And these are some startling statistics about falls. About every second, a person of older age falls every day. 1 out of 2 or 1 out of 4 older adults fell in the year of 2014, and falls are the #1 cause of hip fractures. So this is a graph. I don't know if you guys can see the very top of it because let me move this. This is a graph that highlights, as we age, kind of the significance of having a fall and traumatic deaths. So early on in your 60s, we see that there are more, or there are other causes of traumatic death, like motor vehicle accidents, and fall being one of the kind of lower causes of death. But as we age into our mid-70s, that quickly spikes up and becomes one of the, and if at the end or later portions of the 80s, becomes the most common cause of death. And this is another graph that shows essentially that not only are we finding that fall is more prevalent later on in life, but we're also finding that the severity of fall is getting worse with time. So the deaths per fall has been increasing over the past several years. So it's really important for us to minimize the risk factors of falling and prevent people from having them in the first place. So what can happen if you do have a fall? What I mentioned earlier is that we are very worried about serious falls leading to injury. And about 10 to 25% of falls do result in injury. Fractures are a big concern. After a certain amount of time, we start to lose muscle mass, we start to lose subcutaneous fat, making it a little bit harder for our bodies to take an impact. We also see that as we age, we're more prone to osteoporosis. And so if hip fracture can easily change the way we ambulate and can cause chronic pain. Also, a scary fact is about 20 to 30% of people who have a hip fracture over the age 65 die within a year of that hip fracture. And then another very concerning complication, traumatic complication of falls is an intracranial bleed. So Dr. Love, about a week ago, or a few weeks ago now, had given a lecture about different types of strokes, one of them being a bleeding stroke. And what can happen after a fall is someone, if there's a traumatic impact to the head, it can cause a bleed within the brain. And that can unfortunately be quickly debilitating and can lead to death as well. You can have dislocations and sprains, which come off, or as we're familiar with them, those are more recoverable, but they can lead to significant pain and a need for rehabilitation, as well as bruising and abrasions, and just all the other reasons to create kind of a sense of fear of falling, to have any of these events again, which I'll talk about a little bit in the future. So if you do have a traumatic fall, it can lead to hospitalization. And hospitalization, unfortunately, while people are in the hospital, you're less likely to be walking around and more likely to lose that strength that you once prior had, leading people to be weaker when it comes to doing the things that they used to be able to do, whether it's taking their own medications, walking around the home, cooking, cleaning. And so hospitalizations can lead to an increased need for care, needing a home aide or needing a family member or loved one to come help you out around the house, or help you do things that someone might not have been able to, or may have been able to do on their own before. If it gets to be an extreme level, people can lose the independence that they previously had. So living on your own or having a very small support system, now needing to go to be living with someone that you weren't previously living with, or living in a nursing home, it's a very dramatic change in someone's lifestyle, and that can be it can be very tough. And then developing a fear of falling, which is a phenomena that makes it more difficult for people to rehabilitate and strengthen and prevent future falls. So what is the fear of falling? It's an event or a phenomena in which someone has a large amount of distress over the feeling of unstable gait. And that fear is actually a completely normal fear after a change in the way that someone walks. It's when it becomes an irrational fear that it becomes a problem. And it's when people start to change what they do day to day when it enters this cycle. And how people kind of avoid this fear is by minimizing how much they ambulate, minimizing how much they go out and do the things that they used to like before, like going to the grocery store, seeing a friend, walking outside, gardening, whatever the case is. It leads to this inactivity. And that in turn makes you more weak. The lack of exercise, you'll lose muscle mass, you'll lose that strength. And then that becomes a cycle for worsening gait, worsening fear. And it's a vicious cycle, and it's very difficult for some people to get out of. And I think it's really important to realize that it's a normal fear. It's once it affects someone's life is when it becomes a problem. So I'll go over risk factors that we can't control. And I won't harp into these too much, because if life gives us lemons, we make lemonade. But these are non-modifiable risk factors. These are age, ethnicity, and cognition. Unless you find the water that Tuck Everlasting drank, or you have the genetics of Benjamin Button, there's nothing you can do about changing your age. So, it's something we're all subjected to, is getting older and wiser, and we should embrace it. And then ethnicity, we see that people of Asian descent have less falls, and we see that people of non-Hispanic Caucasian descent typically are at higher risk of falls. And then lastly is cognition. So people that have any kind of dementia are at higher risk of falls. But let's talk about things that we can control and that are modifiable. So I'll go through these in about 3 categories. There's environmental. That's the things that are around us, things and people that are around us. The second is physical. That's how our bodies are functioning. And then the last one is behavioral, what we're doing to our bodies and what we're taking into our bodies. So environment. I think it's good to look at environment in 2 different things, or in 2 different aspects, people and things. So the people that are around us, and then the objects that are around us. And we know that anyone who lives alone and doesn't have a close support system is at higher risk of serious falls with injury. And so it's recommended that you, or that anyone with a higher risk of falling or fear of falling has a support system nearby them, whether that is a family member, a friend, a roommate, a home nurse, whatever the situation is, but having that someone close by that you can call to. And not everyone has that, and that's all right. So there's this development of a medical alert company. And luckily throughout the years, there have been more options, which has kind of driven the costs down a little bit and given a little bit of freedom to people who do want to go forth and get one of these. But essentially, you have a button or some kind of a device which either hangs around your neck or is a watch-like kind of wearable. And if someone has a fall or is fearful of falling, they can push that alert button, and that will go through a telephone system and alert emergency medical personnel, who then can come and respond appropriately. And they've are still pretty expensive, on average about $20 to $30 a month. But there are some that are a little bit lower, like $15, $16. But these are a nice alternative for people who might not have someone close by in the area. The next thing is the things or the objects that are around us. And we see that maintaining or limiting kind of the risk factors and of the objects that could potentially cause us to fall is really important. So maintaining proper lighting, a bright lit area in dark halls or stairwells is very important to ensure that we're seeing the ground that we're walking on. Slippery floors that can cause easily misplacement of a foot and causing people to slip should be minimized, whether that's through a non-slick sticky mat or a non-slip rug, or minimizing the amount of time that someone is standing in that slippery area. So in the shower, some people are able to get a chair, and then physical obstacles that are in the way. So things that are along the floor that might trip our feet up, like area rugs or cords, books on the floor. Along with this, things that we have to reach for. So needing to get on a step stool or a ladder to get to something within the garage or something on a tall cabinet increases our risk of fall. So having things that are available so that they're easily accessible and reachable without needing to use the step stools. And then having support systems throughout the house or home, like grab bars along the railings of stairs or grab bars within a shower, can really help people provide extra support for people who might have a slip in those areas. I think this is a good representation of how chaotic our lives can be and the places that we live in. And it's all too common to myself and I'm sure a lot of other people, but cords strung throughout the home, all sorts of stimuli that are making you feel like you need to go one way or the next, whether it is a coffee pot that's going off or a TV or a cat that's playing with a unstable cord. But minimizing all of this potential for a risk can prevent that kind of perfect storm for a fall. So the physical risk factors that we can adjust for, I like to talk about in terms of feet, ears, and eyes. So footwear is really important for prevention of falls. We see that people with open-toed shoes or high heels and or are barefoot are at higher risk of falling. And so having a comfortable shoe is really important. Something that fits firmly and doesn't feel like it will fall off your foot, but is also not too tight. Having a kind of a flat surface or a flat sole with a lot of surface area to connect to the ground, as well as being textured so that if there is a little bit of a slip or water that shoe can catch. And then preventing changes or preventing things that can affect the way that we step. such as foot pain or neuropathy. So having an ulcer on the bottom of the foot, having an ingrown toenail, having a bunion that's been bothering you to the point where you're changing or someone's changing the way that they step and plant their foot on the ground can predispose that person to falls. And so following up with a podiatrist or a foot doctor, making sure you see whether you go to a salon and get your nails cut, or making sure that you don't ignore that thing that's been causing you discomfort for a long time, because that can affect the way that you walk around. And then neuropathy is a phenomena or it's a disease that happens where you have a change in the sensation of your lower leg or foot. And that can affect the way that you feel yourself taking a step, or the way that you take this step. And so minimizing the causes of neuropathy, like controlling your diabetes, controlling any back pain, is really important as well. And then ears and vertigo. Ears are so important to our total sensorium and adds a lot of information to our environment. And ignoring hearing loss can cause problems and make you at higher risk of falls. And so, for example, if someone was to drop a ball and it was rolling on the floor and you were unable to hear that, you wouldn't necessarily, or someone wouldn't necessarily look down and realize, hey, I need to make sure that that ball is not in front of me. Or whether someone has a pet, a cat or a dog, and that pet runs in the room and someone is unable to hear that pet, it's important for us to realize that if we could maximize the amount of that we're hearing, it could potentially prevent us from having that happen and causing a fall. And then vertigo is, we have a connection with our ear to a balance system, and having things like ringing ears or a feeling of dizziness is associated with falls, and making sure that we go to our primary care doctors and we have, and we get these conditions addressed to prevent that feeling of unease or imbalance is also very important. And then lastly, eyes. If you feel like your vision is bad, that's enough for us as the medical community to know that you are at a higher risk of falling. And there's a few big things that we like to make sure are maximized, and that's depth perception, or how you're able to decipher distances, acuity, which is how sharp someone is able to see, and then contrast sensitivity, which is the ability to decipher two things that are next to each other that are different. So things that can affect those, things that can affect depth perception, acuity, or contrast sensitivity are things like cataracts, glaucoma, macular degeneration. And so ensuring that you're going to your eye doctor annually and making sure that those conditions are maximized in terms of maybe surgery or cataract surgery is recommended for you, and having that done. We also see that diabetes and high blood pressure can acutely change the way that you see. So if someone has uncontrolled blood sugars or uncontrolled blood pressure, that can change your vision very rapidly and quickly. And it can also change your vision over a long period of time. So making sure that those are well controlled can help improve your seeing. And then we also notice that people with bifocals, trifocals, or progressive lenses are more likely of falling, or more likely to fall. And that's because the base of the lens amplifies what is your visual field. And that can distort the way that you're seeing the floor. And so when people continue to wear them when they're walking, that image of the floor is not necessarily reflective of how far your foot is away. And so we see that that increases people's chances of falling.
Dr. Spina, if I could just jump in for a sec, 'cause there was a question that came in going back to sort of the environmental factors. So the question being about bathroom grab bars, and this individual saying they know that there are some suction grab bars, but that those don't seem to be as effective. So asking if there are, especially for renters, are there any sort of resources out there that could get those sort of services installed in someone's home?
That I'm actually not sure about. I don't know if anyone else on the panel knows, but I know I am weary of the suction grab bars because they are not permanent, and they can disconnect from the wall. As of services, I think talking to your landlord or talking to the place that you're renting from and asking if they're able to install anything. Brooke,
Yeah, no, I think those are excellent points. I agree about getting them installed so that they're secure. Philadelphia Corporation for Aging does have a program, I think it's called their SHARP program, where they do some home modification. So that may be something that someone, I don't know if they can compel the landlord to put them in, but that they might put them in residence home.
Yeah, that is, PCA does have the SHARP program that will do some of those home modifications, but yes, I think it is for homeowners. So it is a different process with renters. PCA though should be able to, if they're not able to do it themselves, offer those referrals. I can drop their helpline number into the chat. Someone also shared in the chat that there is a way for folks to apply for their landlords to do that if they can have their doctor fill out a form. So we can also try to find out that information. So thank you. You can pick back up, Dr. Spina.
So the next thing I will review is physical risk factors for fall. So physical meaning our bodies and how they function. We see as we age, unfortunately, we lose muscle mass and we lose some strength, but we can combat that with exercise to improve our strength and our endurance. And the goal of exercise is to maintain postural stability, meaning the ability to stand up or keep an upright posture, keep a centered core, joint mobility, how fluid we're able to move our hips, our knees, our shoulders, and then postural reflexes is when some force comes along and can disrupt your postural stability. So if someone is to push you from behind or there's a slip on the floor, maintaining and being able to go back to that core strength is really important. And the way we can do this is exercise at home. For people who need a little bit more assistance, physical therapy and occupational therapy. And then there are also all sorts of fall prevention classes which offer exercise programs as well. So it's recommended to do at least 150 minutes a week of moderate intensity exercise. This is things like swimming, brisk walking, this can be shopping, this can be cleaning, as well as bicycling, or 75 minutes of vigorous intensity workout. This is like running, doing stairs, exercising with sports, as well as 2 days a week of muscle strengthening. So things like yoga, lifting weights, carrying heavy bags, and additionally 2 weeks of balance training. What's great for balance training are things like Tai Chi, dancing, and bowling. And exercise can reduce fall rates and fracture rates by a significant amount, by 25%. So exercise is a very cheap and easy way for us to prevent falls. So what we put into our bodies is also very important. So we see that prescription medications things like benzodiazepines. These are commonly used for anxiety or for sleeping. This is Ativan, Xanax, lorazepam, diazepam. Opioids for pain. This is oxycodone, Percocets, morphines, barbiturates like phenobarbital. These medications can alter our reaction time, change our muscle tone, and predispose people to falls. It changes the way we kind of can sense our environment. And so we see that these medications increase risk of falling. So minimizing them as much as possible is preferred. However, you know, understandably, some people can't, some people need them. Things like psychotropics, depression, anxiety, medications, mood stabilizers, antipsychotics, those are similar where they can alter our reaction time to our environment. So talking to your physician, talking to your doctor about whether they are needed, if the medication doses can be changed, if you can do a trial off of these medications, but I highly recommend that it's a discussion amongst you and your primary care physician. And then alpha blockers are another medication we see that are predispose people to falls or increase your risk of falls. These are typically used for prostate enlargement or urinary obstruction, and these medications can affect your blood pressure, which makes you feel lightheaded or someone feel lightheaded, and can predispose you to falls. So highly recommend everyone doing frequent medication reviews with your whoever's prescribing them to you. And then they can become very overwhelming. The number of medications that people are on can become overwhelming in terms of what time of day they're taken, who prescribed it, what it was for, the dosing. And so sometimes it's easier just to bring all of those medications in with you to your office appointment and going through them one by one with the provider. Additionally, with this, alcohol and recreational drugs also affect the way that we sense our environment. They slow our reaction speeds. They make our muscles kind of more relaxed. And because of all those reasons, they increase our risk of falls as well. So the fear of falling, which we talked about earlier, how do we break that very vicious cycle is by staying active, keeping that strength and that balance, progressing and moving forward can decrease our risk of falls, decrease the actual event of falls, and increase people's confidence. So it's really important to break that cycle of a fear of falling, that irrational cycle, is to keep at it, keep going, and don't let yourself become immobile. So when to talk to your doctor, anytime that you feel that you're at higher risk, anytime that you're feeling uneasy with yourself, or you've had a fall, or someone you've known had a fall, or someone you knew was fearful of falling, have them go to their doctor, or you go to your doctor. Your physician can do additional tests, things like orthostatic blood pressures. I had mentioned the alpha blockers used for prostate health or urinary obstruction. Those can cause something called orthostatic hypotension, but those medications aren't the only cause. So testing for it, seeing if that some of the symptoms that you're having of uneasiness with walking is due to it, and being able to find the reason for this drop in blood pressure and potentially reversing it and fixing it. A time to get up and go test is a test where someone stands up out of the chair without using their hands to push up, walking about 9 feet or 3 meters away, turning around and coming back and sitting down. And we can tell that someone is having a higher risk or has a higher risk of falls if it takes them over 20 seconds to do that. If it takes you less than 10 seconds, we know that your risk of falls is very low, and that's reassuring. And so having some of these tests done can give you and the physician a better understanding of kind of where you are or your loved one is. And then a 6-minute walk test is another test that's similar to that, in which someone is to walk and the distance of is measured over 6 minutes. That can give better functional status understanding. And then vestibular testing, that vertigo that I had mentioned, people with that feeling of dizziness, that room spinning around them. Sometimes there are things that your physician can do to eradicate that feeling within the office, or they can give certain medications or refer people to vestibular training, and they can at least help diagnose if there's anything going on in your balance center and help correct that. They can also follow up with looking at things like electrolytes. There are certain electrolytes we know that can affect the way that you're feeling, your alert level, your blood counts. Things like anemia or a low hemoglobin can make people feel tired and more predisposed to falling or uneasy with walking. And then vitamin D, we see that vitamin D adequate levels improves our risk, or decreases our risk of falling, and making sure that we're adequately we have adequate vitamin D levels is really important. So all of that information together, your physician can make a comprehensive evaluation for you or your loved one, and change medications, decrease medication doses, refer to certain support systems, treat underlying causes that could be adding to the feeling of unstableness. And then potentially referrals to things like physical therapy or occupational therapy. And that can be performed at 3 different locations, whether it's in the home, it's at an office, or it's at something that's more vigorous, which is a subacute rehab, where people stay overnight for several weeks and get more intensive physical therapy and rehabilitation. We'll talk about walking devices a little bit as well, so they can also help with determining if you would benefit from a walking device or someone you love would benefit from a walking device. So a crutch is a temporary walking aid. I think most people are pretty familiar with a crutch, but it's really a tool to use for an injured body part in hopes that that body part will heal. So the crutch is fit such that the armpit pad is supposed to be 2 finger widths below the armpit when standing. It should create a nice small angle at the wrist and at the elbow and the wrist when gripping the lower part of the crutch. And it's important to realize that the lower part of the crutch, where the hands are grabbing, is really supposed to be where most of the effort goes. Having too much weight in the armpits can cause nerve damage. There are a series of nerves that run through the arm that are really important for the way that your hand and your arm move, and too much pressure in the armpit can hurt them and cause damage. So the support should be within the hands, but that takes a lot of upper body strength, and so that can be a limiting factor for some people using them. And again, they're really only supposed to be a temporary walking aid. So a cane is the most common, but what is concerning is 70% of people who start using a cane start using them incorrectly. And because of that, 50% of people that start using the cane that are using them incorrectly will stop using it. So the cane should be measured such that it ends at the wrist length when standing up straight and arms at the side. There should be a small angle within the elbow and the wrist, as you can see with the gentleman right here. And it should be held on the opposite side of injury. It's usually used for if there's one side that's in pain or injured or feeling weak. And it's not the best for when you have injury or pain on both sides of the body. And so there are so many different types of canes. There are ones with knobs, there are ones with handles, there are ones with 1 peg, 2 pegs, 4 pegs, 3 pegs. there's a ton. And so it can get very overwhelming. What cane would be suitable for me? You can get canes with elephant heads and wolf heads. But what we see is canes with ergonomic handles, meaning a nice handle that suits the hand and prevents slipping from out of the hand, is tolerated by most people. Also, there are multiple options for pegs at the bottom. Each should have a rubber bottom that prevents slipping. But one peg, as you can imagine, has a little bit less stability. This is easily to maneuver and lift up off the ground. 3 pegs and 4 pegs add a little bit of weight. And so while they add more stability, the user needs to have a little bit more of upper body strength to carry them.
Dr. Spina, we just had a question come in about canes.
Yeah.
The question is, how about utilizing a cane if you have a drop foot? And so if one foot is dragging, are you going to use the cane? Should the cane be used on the side that is not dragging? I think is the question.
The cane should be, just like before, the cane should be used on the opposite side of the impairment. So if the foot drop is on the left, your cane should be held in the right hand.
Great, thank you.
Mm-hmm. And so I have a quick video on how to walk with a cane, and kind of a little bit about the measurements of getting the right size cane.
To properly fit, first place the tip of the cane against the side of the foot. The top of the cane should be about wrist height, so this is too high. Make the adjustment and try again. Oops, it's now too low. It's not at wrist height and the elbow should never be straight while holding the cane. Keep adjusting until you get it correct. Now it is at wrist height with a slight bend in the elbow. Perfect. The optimal way to use a cane is to place it in the opposite hand of the weak or involved side. In this case, his left lower extremity is involved. To practice the correct pattern, stand still and move the cane and the involved side together. When you dance, you move with your partner. The cane and the involved side are partners, so they always have to move together. Together, 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 together. Note that the angle of his leg and the cane are the same. This is correct. This is not correct. The cane is now on the same side as the involved side. This is also not correct. The cane is the correct hand, but it is not moving together with the involved left side. Again, not correct. The angle of the cane and the angle of its involved side should be the same. Going up the steps one step at a time, step up with the uninvolved side first, followed by the involved side and cane together. Always remember to hold the rail. Going up the steps reciprocally, simply keeping the cane on the same step as the involved side. Remember, they always go together. When coming down the steps, step down with the involved side and the cane first, then followed by the uninvolved side. If done reciprocally, simply keep the cane on the same step as the involved side. Remember to always hold the rail.
All right. So walkers are the second most common walking aid, and they're used to aid when injury is on 2 sides of the body. There is a standard walker that has 4 pegs on the bottom. There is a two-wheeled, which has 2 wheels in the front and 2 pegs in the back. And then there's a 4-wheeled, which has 4 wheels. The standard is kind of what is typically started with in most people. It's great for if someone feels like they have the sensation that they're going to fall forward, but it's a little difficult to pick up because there are 4 pegs. So that is a limiting factor in people being able to use it freely. And then there is a 2-wheeled rolling walker, which also provides front support for people who feel like they're going to fall forward. But it's easier to maneuver with around an area, and people are able to glide it along the floor, which can help continue and not have to pick it up. It does have difficulty making sharp turns. For that reason, some people go forth with a 4-wheel rolling walker. A lot of people also know them as rollators. And these come with things like a seat, a basket to carry things. And for those 2 reasons, a lot of people really like them. They have brakes because, as you can imagine, with 4 wheels, you can easily lose track of the rollator or the walker. And the turns are very sharp and it moves a lot faster. So there's a higher skill level needed out of the operator or whoever is using it to use it properly. And so people who generally start using any walker, it's recommended that you work with occupational therapy to make sure that you're really truly using them to their full potential. Some resources, there's the CDC study, which has a lot of information, a lot of reading materials for you. There's also fall prevention course for people out in Lancaster area. There's Lankenau Medical Center and Paoli Hospital that have these hotline or these phone numbers that you can call to see if they have any upcoming programs. For those who aren't in that area, there's University of California SD also has webinars. So for you that are electronic savvy and like doing webinars, you can go to stopfalls.org and sign up there. There's also services, which you guys mentioned through PCA, and then Pennsylvania Department of Aging also has a website that you can go to, place your county and select dates that you are interested in going to a fall prevention program. They have fall prevention programs that review risk factors, again, like we did today, and helping minimize risk factors in our lives, and then also exercise programs. And then they can list, it lists contact numbers and locations for different programs that are available. Also, there is, I placed at the bottom a checklist, which PDA also provided, and it goes through a lot of the things that we talked about today that are easily modifiable at home and hopefully very, very affordably. So just to review everything that we've talked about this afternoon, is falls can lead to serious injury and even death. And people with a history of falls, a fear of falling, impairment of your sensation, whether it's through medication, vision, hearing, substance use, or an unstable environment, all increases our risk of having falls. But these are modifiable and we can do something about that. So this is just a nice schematic again, which are things that you can do at home really quickly and easily and cheaply for yourself or someone that you love that you're fearful of falls, is making sure that there's those grab bars, which we talked about, we'll hopefully get you more information on, handrails, non-slip rugs and mats in areas that are slippery, avoiding things on the floor like area rugs, cords, ensuring that the floors are sturdy and stable, improving lighting in areas that are dark or dim lit, going through our medications with our physicians pretty regularly, and then asking for help when we need it. So talk to your doctor. They can identify and treat medical conditions that can lead to falls. They can reduce polypharmacy or multiple medications or provoking medications to falls. And if needed, they can refer you to things like physical therapy, occupational therapy, or other balance therapies. And then proper cane and walker use are important really to get that maximal support that they're intended for. And there is a ton of help. When in doubt, just to reach out. Any questions?
Well, thank you so much for that, Dr. Spina. And would encourage folks in the few minutes we still have here, if you have additional questions, feel free to throw those in the chat or in the Q&A feature. And for anyone with us on Facebook, feel free to leave a comment and I'll relay those questions. One of the things I wanted to ask Dr. Spina, because you sort of alluded to it with talking to your doctor and how they can make some referrals, but for someone who does have some of these concerns, might think they need a cane or a walker, is that something that they should make an appointment with their primary care doctor or with the geriatrician? Are they trying to find a physical therapist on their own? What's sort of the easiest point of entry for navigating that?
So I would say go to a physician or a practitioner of any sorts. It doesn't necessarily need to be a doctor. It could be an NP or a PA that's able to provide care. But to go to physical therapy, often it's required to have an insurance referral so that it's covered. They can kind of go through some of the things needed for a cane or a walker. You can purchase canes and walkers without prescriptions from a physician or a provider, but I encourage people to do it through someone who knows a lot about it so that they're using them correctly, they get the correct sizing, and they know all the tools to use them.
Great, thank you. I know we also talked about last month when we were talking about stroke, that one of sort of the after effects of a stroke is an increased fall risk. So we did talk a little bit last month about sort of how physical therapy, occupational therapy can tie in with the reducing the risk of further falls. So I'm glad you touched upon that too. I know we're getting towards the end of summer and it's going to be getting cold again soon. I also assume that, with winter weather, you see a bit of an uptick with falls, aside from the obvious of good footwear and keeping an eye on the ground. Any other tips for winter with, getting around the city in a icy and slippery and sleeting weather?
Yeah, so I would say avoiding those moments where there could be a slippery ground, choosing a cleared path, choosing a salted path, because even though that salt can help kind of melt the snow, it can also act as some friction and help people help people get a better, grip on the ground and prevent falls. If they do need a walking aid, to ensure that you're using it during these slippery months, and to not be afraid of asking for help from a friend or a loved one if you do feel unsteady, and grabbing an arm if you need to.
Any other questions from folks in the Zoom? If not, it looks like we're just about at 2 o'clock, so we can wrap up. But wanted to give a big thank you to Dr. Spina for joining us here today and for sharing all of this information. This was great. A lot of good resources in here.